Hello, Nursing 122, and welcome now to a little vignette to watch about cerebrovascular disorders or strokes. And what is a cerebrovascular disorder slash stroke? Well, it's something that's affecting about 500,000 Americans a year. That data could be different from when I looked at it here a while back, but 500,000 people. A stroke is kind of like a, quote, brain attack. It occurs when blood supply is cut off from part of the brain. And for every minute that the brain cells are deprived of oxygen during this condition or this stroke, brain damage increases. And the chances for survival and recovery improve when treatment begins within the first few hours of those stroke warnings. And we're going to be talking about those in a few minutes. But just to let you know, functional abnormality of the CNS is the central nervous system that occurs when the blood supply is disrupted to the brain. If there's disruption to the blood supply to my brain, that becomes a neurological disorder then. Brain tissues fail to receive adequate oxygen, I just got through saying too, and recovery depends on how quickly you can get the flow going. I do want to point out too as well that strokes have been listed as the primary cerebral vascular as the third leading cause of death in the U.S. And it causes a lot of our long-term disabilities or our chronic issues that we've talked about before. And the direct and indirect cost of a stroke to our country, the last data that I just got, was $53.6 billion. And that's very sad on something that has a lot of prevention that could be tied to it. If we look here, it's a change in the normal supply of blood, and there's several different things here to keep in mind. One is there's two types of blood. There's one that's ischemic, and it's an interruption of the blood supply. It could be like there's a clot blocking the vessel and the blood can't get through. Or it can be like a hemorrhaging, where there's bleeding from a vessel and that causes increased intracranial pressure in the brain, and that causes things to get cut off and not get the blood supply that they need or the oxygen. Just to remind you from anatomy, the brain is unable to store oxygen or glucose for that matter, and that is why there needs to be a constant flow to the brain for things to go work well. If blood supply is interrupted, even for just a few minutes, then you've got cerebral tissue damage. It's going to die. There's many risk factors for strokes that you can look at here. The one up here, the TIA, is the mini stroke, which we'll talk about here in a little bit. So people that have these ischemic attacks periodically, have a history of those, are more at risk to have a stroke, because those are kind of like warning signs. Some of these symptoms, if you look at them on the list, I'm going to point out that some can be controlled and some can't. I cannot control my age. That's something I cannot control, and I cannot control my family history. Those are two things that as people increase in age, so does their increased risk factor for stroke. So I would add that to my list as well. But those two things I have no control over. My family history I do not. But things that I do have control over is I do have control over hypertension. I do have control over high cholesterol. I do have control over diabetes and heart disease and keeping those things in check, and smoking and the diet that I eat. A few things that may not be up here that I may not have added. High cholesterol could get added to the list. Makes you at risk. That's a risk factor. If you look up there, I have lack of activity, but I don't think I said obesity. And so obesity could be one of the things that you could add to that list. Excessive alcohol intake is a risk factor that increases illegal drug use. They're finding that a lot of these different substances are starting to cause people to be at risk for strokes. And certain blood disorders could be put up here as well. Like I said before, risk factors that cannot change is as you get older, so does your risk for having a stroke. They say that once you turn 55, your risk of stroke practically doubles every decade. That's something to keep in mind too. I can't change that, so if I'm getting older, I need to watch the other risk factors. Risk factors for strokes, I would like to add to this list that men are more likely than women to have a stroke. But the data shows that more women die from a stroke than men. Genetics, we've said before, we cannot change, and our race we cannot change. They have found that African Americans and Hispanic Americans are also at a higher risk for strokes. And like I said before, if you've had a prior stroke before, you're more at risk for having it. So this list was not totally complete. So the people watching this will get more information to put on there, which is very important for the purposes of an exam. I would also like to add here other things that make you at risk for a stroke is if you have existing cardiac conditions. And if you have AFib, where the heartbeat is irregular, that could increase clots. Also, maybe a surgery where I've been bedridden for a long time makes me at risk for DVTs, which could make me at risk for strokes. Kind of putting it all together. Signs of a stroke, they're sudden onset. And a few here that are listed, the sudden numbness or weakness of the face, arm, or leg, especially when it happens on one side. Sudden confusion, trouble speaking or understanding. You all of a sudden have vision problems. You have sudden dizziness, loss of coordination, trouble walking, sudden headache with no cause known. Those are the signs you need to be looking for. And these are signs that mean that somebody needs to get medical treatment. And a lot of times people put these things off because they hate to go in and have it be checked out and have people tell them that something's okay and go home, especially with how things cost nowadays with health care and everything. I included this in the PowerPoint just so you get an idea of the pathophys about what's happening inside the body when the cells are not getting the oxygen that they need and ischemia is happening from an ischemic stroke point of view. I do want to point out that any stroke is a medical emergency and needs to be treated immediately so that there is no permanent deficit or disability from it. Good assessment is what needs to be in place for the nurses. We need to make sure we're looking at cognitive changes. How is the person talking? How are they? The things we went over and the signs and symptoms, those are all part of a neurological exam. Those are very important. We need to look at like the motor, the sensory, and do a cranial nerve assessment. So if you do not remember those 12 cranial nerves, those are something that you might need to know if you're working in a neurological unit, because those cranial nerves kind of dictate when there is ischemia in the brain. Some of those nerves are going to be impacted, and we need to know how to perform that assessment. Plus, if there is something that's with these changes and you're thinking stroke, you need to cardiovascular assessment as well, in case there is some blockage or something that's causing that. The testing that they will do on a person is the good old MRI and CT scan to look at how things are going, to see what the evidence are. Is this something that's caused by hemorrhaging or is it caused by blocking? Sometimes they may even do a lumbar puncture. If there's a lot of neurological changes and they're not for sure if it's a stroke, they could do a lumbar puncture. If there's blood in it, that reveals that there could be a hemorrhaging, and that could be the cause of that stroke. Also, they may even do a cardiac an ultrasound of the carotid just to see if there's blockage in that carotid artery, and that's causing you to have ischemia to the brain. So there's two types of strokes, and it's testing to see what's happening. The ophthalmologist is usually someone that can usually detect what's going on because they can tell by the vessels in the eyes hypertension and if there's any problems with the renal arteries. And an EEG also shows you the brain pattern, brain waves, and lets you know where there might be damage at. Like I said before, there's two types of strokes. The most common stroke is that's ischemia. So a lot of doctors, if there's an emergency and they're not for sure yet what it is, they start treating it as it's ischemic until they get more data. This is a little chart that I put together that I thought might kind of help explain things. It tells you kind of like the onset. If you look, strokes are very sudden. If it is a clot that's come loose, traveling, it could be over time. Level of consciousness is what LOC stands for. It kind of tells you what you would see. If there's bleeding, the person's not going to really be staying awake very well. The person is probably going to be starting to go into a stupor or a coma and becoming very hard to arouse, like you have found out when you've talked about your information about when you did neuro assessments last semester. If you look here, the CSF stands for cerebral spinal fluid. And usually, if there's neurological changes, a lot of doctors might tap a person if they're not for sure totally if it is a stroke or not. And most of the CSF is going to look normal except for if there's hemorrhaging, there would be blood in your cerebral spinal fluid. And so if we look here, seizures, most of the time you don't see seizures with strokes unless you have someone that there's hemorrhaging. And the big thing about hemorrhaging is with ischemia, it's just loss of blood flow going. And with hemorrhaging, there's loss of blood flow because there's so much filling your skull, and your head and your skull can only hold so much. And if there's so much up there and it's putting pressure on everything, that could trigger like seizures to different parts of the brain seizing. The TIA that we talked about before, I feel like I'm at the airport, is temporary. It's a little mini temporary stroke. And it can last seconds to hours, but typically 30 to 60 minutes. And the person would start to have no deficits after 12 to 24 hours. And it's usually a warning sign that something's happening. And in 50 to 80% of the patients who have had some type of clot, they have experienced this, and it's been something that they've been able to get help for before the stroke occurred. With a TIA, workup would be done, and they would not only check neurologically the brain with a CAT scan or an MRI, but also like your carotids, and they might do an echocardiogram to see how the heart is. Some of the signs and symptoms, as you notice on here, look a lot like the signs and symptoms of a stroke. You just got double vision, your coordination is off, you're having trouble speaking. And how do we prevent this? Well, to prevent a complete stroke, if you're starting to have TIAs, a lot of doctors will put people on aspirin and anticoagulants to minimize the risk of forming a clot. And possibly they may have to go in and have their carotids cleaned if their carotids are blocked. The general rule of thumb, and this is not limited to this, this is just a little bit of what they would do for stroke therapy once a stroke has occurred. They would give low doses of aspirin. When you see a client on an aspirin, and it's an 81 milligram dose, 81 milligrams of aspirin is not going to do nothing for pain or fever or anything, but it helps your blood to become slippery. so that it doesn't start to, I would call it an anti-clot forming because it's a slippy, I'd call it a slippery agent because it keeps that clot from forming. If there is a clot there, it keeps the blood, makes the blood slippery so it doesn't just keep jumping on that clot to make that clot even larger. There's a lot of antiplatelet agents that are being used to help that with the clotting as well. Once somebody's had a stroke, they may be at risk for seizures depending on, like I said, on the onset, the chart that you looked at earlier where it said seizures, that was seizures like when the stroke is happening, but we know that you could have a problem if it's been damaged to a certain part of the brain severely or if it was through hemorrhaging, and so you might see agents being used like that to help the person stay stable. Other things for stroke is you've had an kind of like attack to the brain. You have had an attack to the brain. It's not kind of. And stool softeners are used to prevent intracranial pressure, ICP. Because if I have to strain, and I've already got areas that need to heal, that might cause more problems. They may actually give people too corticoid steroids to help bring down the cerebral edema after a stroke. Because when there's injury to any part of the body, cells start to go there to protect that body, and that's where you get the inflammation. And in some cases, if a person's got hypertension or they have like rhythm issues with their heart, there may need to be medications given for that as well. Usually within, the books vary on this, between 2 to 3 hours. And I think it would be the protocol of the institution where you are. The onset, the best onset for administering and treating an ischemic stroke is to get help within 3 hours after that stroke has occurred. And to be able to administer this little thing called RTPA. And what this is it's like the Drano of clot busters. If the cause is an ischemic stroke, this is a tissue plasma activator. It's a clot-busting drug that works quickly to dissolve a clot and restore blood flow to the brain. It must be given within the first few hours after the symptoms start for it to work. It's not appropriate to use on people who their stroke is caused by hemorrhaging. 80% of the strokes, like we said, to 85 are caused by ischemia, so this works on the majority. When you're using something of this nature, there are protocols, there's informed consents that need to be obtained. Because since this is the Drano of clot busters, you always run the risk of getting rid of the clot and taking care of the problem you're trying to take care of, but because it increases bleeding, it could cause more issues as well. So people need to know that this could help, but it could have some bad side effects too, like intracranial hemorrhaging and bleeding. There's protocols for the administration of this drug that need to be followed based on what's in your institution. They normally take someone to a unit so that they can have closer monitoring. And the amount of the drug that the person gets is based upon their body weight, because you can't give two different size. I would not want a 250-pound man to get the same dose as a little 90-pound lady. So there is some weight base on that, and there is math that needs to be done to figure that out. Just to let you know too, is even though they use this, these drugs help reduce the risk of blood clot. Sometimes this is not even the answer. Sometimes emergency surgery is the answer, because if it's a hemorrhaging, they need to repair the busted vessel, and if it's blocked, they might have to go into a vessel and open that vessel. And so whether it's surgery or the use of this drug, you might see both. The thing that I gotta keep saying is the minute someone thinks they're experiencing signs and symptoms of a stroke, they need to get immediate attention right away. there's a lot of aftermath that can come from having a stroke. And it could be different for every single person that experiences a stroke. Because it's all going to depend on what part of the brain has been affected. And if you look here, it can affect vision, motor function, sensory function, your ability to speak, your ability to understand, and even your emotions. And they have also found in some of the newer studies that people that have strokes are at increased risk for suicide because of depression. So all of these things are happening because the brain has had lack of oxygen, parts have been damaged, cranial nerves have had dysfunction, and we have those chemical messengers up there, the neurotransmitters that are transmitting things, that gets disrupted as well, which is part of depression in a lot of cases. So you may even see as part of the treatment plan that people are given antidepressants because we know that this is something that could possibly be a problem. So this is all something to keep in mind. So on to the next little thing. There is something out there called neglect syndrome. And what neglect syndrome is, it's affiliated with strokes. And it's affiliated with strokes that are in the right hemisphere. And wherever the stroke is located, then the opposite side of the body is usually the side of the body that you see affected. And so this is happening in the right hemisphere, which means usually the people don't even know that other side of their body exists because they cannot perceive it, they cannot kind of see it. I had a patient once that the student put their milk in front of them on that side of the body, and they could not see the milk, even though the milk was there, and they were yelling at the student because they hadn't brought him their milk, but they just couldn't see the milk because of their perception being altered by it being in that hemisphere. Usually people that have neglect syndrome, that's usually something in most cases that does not go away. They end up having those issues all the time. And therapy, physical therapy, OT therapy, all the people need to work together to help that person to be aware of that so that they can manage that problem. I remember seeing one person wheeling themselves down the hall in the wheelchair, and they had that one side of their body all getting tangled up in the spokes of the wheel. They didn't even know that it existed. Prevention and treatment is the most important thing. Once the stroke has occurred, we have got a lot going down to try to get that person back to a state where they can be the best that they can be. And then there's going to be long-term management that's associated with that. So if we can help someone before they have the problem, that is the best, through health maintenance. And also, they have found treatment of periodontal disease. They have found that good dental health goes hand in hand with a lot of these cardiac issues. Seeing if someone has clogged arteries, carotids, and having some issues to get those cleaned in time. Anticoagulant therapy for people that they think are at risk for clots. They may put them on things of that nature, or antiplatelets. Some of the statins or antihypertensive meds. You're treating the problem, keeping the problem in check so that that person doesn't have something like a stroke that's going to cause even a greater disability. Let's prevent stroke. We cannot prevent our age, our race, and our gender, but we can prevent and keep our hypertension in check. We can take the medications that are required for our cardiovascular disease. Our cholesterol can be kept in check. Obesity, we can work on that. We can keep our diabetes in control. Oral contraceptive use is something that you can ask the doctor if there's a lower dose that works better. This isn't all the books, but nowadays most of the oral contraceptives are a little bit lower in hormones than they used to be when they first came out on the market. And basically, smoking and drug and alcohol abuse is a no-no, so that we don't have these issues or these problems. So that concludes our little mini vignette on strokes. And so I hope you enjoy it, and I will talk with you later. Bye.